Good morning. Today we will discuss about leukemia. Contents include introduction, prevalence, classification, etiology, oral manifestations, dental considerations, conclusion, and references. To start with, leukemias are hematopoietic malignancies in which there is a proliferation of abnormal leukocytes in the bone marrow and dissemination of the cells into the peripheral blood. The abnormal leukocytes replace normal cells in bone marrow and accumulate in other tissues and organs of the body. Prevalence in India annually, more than 10,000 cases of childhood leukemia are reported, out of which acute lymphoblastic leukemia accounts for about 60 to 85% of childhood leukemias. Classification include leukemias are classified on the basis of cell types into myeloid and lymphoid on the basis of natural history of the disease, acute and chronic. Etiology include ionizing radiations, cytotoxic drugs, and chemical carcinogens. Inherited syndromes such as Down syndrome occur more commonly in whites, Epstein-Barr viruses, smoking, immunological deficiency states. Acute leukemia, these are characterized by predominance of undifferentiated leukocytes, precursor or leukemic blast cells. Acute myeloblastic leukemia is 4 times more common than acute lymphoblastic leukemias. Acute lymphoblastic leukemia, it accounts for most of the childhood leukemias. Highest incidence is between 2 to 5 years and a second peak after age of 50. Childhood acute lymphoblastic leukemia is predominantly of B cell phenotype. The clinical presentations results from bone marrow infiltration by leukemic blast cells. Oral manifestations include early symptoms is associated with pancytopenia, fatigue, dyspnea, fever, pallor, weight loss, and bleeding. Intraorally, we can see mucosal pallor, gingival bleeding, ecchymosis may be noted, lymphadenopathy of the head and neck region, which is a consistent sign, petechiae or hemorrhage in skin and mucous membrane, bone pain and tenderness, vomiting, nerve palsies. Pericoronitis may also correspond to an initial manifestation of acute lymphoblastic leukemia. Next is chronic lymphocytic leukemia. It is a slow progressing malignancy involving lymphocytes characterized by accumulation of long-lived non-functional B lymphocytes, frequently in Western countries, comprising from 25 to 35% of all types. Chronic lymphocytic leukemia may be misdiagnosed because of clinical features mimicking other diseases. Oral manifestations, in 17% of oral lesions are seen in vestibule and gingiva. It may present as a local swelling with or without ulceration and pain. Tongue is frequently swollen and dark. Regional lymphadenopathy, loosening of the teeth due to necrosis of pedial ligament. Next is acute myeloid leukemia. Acute myeloid leukemia is relatively an unusual disease. It accounts for approximately 25% of all types of leukemia among adults. Incidence of acute leukemia constitutes less than 3% of all malignancies, and it is still leading cause of death in childhood. Oral manifestations include weakness, easy fatigue, infections of variable severity, hemorrhagic findings such as gingival bleeding, ecchymosis, epistaxis, and menorrhagia. Most prevalent oral signs and symptoms are gingival bleeding, oral ulceration, and gingival hyperplasia. Gingival overgrowth varies in severity from minimal to complete, tooth covering, impairing functions and aesthetics. Oral manifestations of chronic myeloid leukemia, enlargement of gingival and mucosal tissues, direct leukemic infiltration. Dietary risk factors for childhood leukemia are diet has been linked to several cancers in adult and children. Maternal diet, food groups include consumption of fruits and vegetables. Reduced risk, negative association is associated with maternal consumption of fruits and vegetables and risk of childhood acute leukemia. Alcohol, maternal alcohol intake before or during pregnancy has increased risk of childhood leukemia. It causes altering immune functions or by teratogenic effect on cell differentiation. Antagonist to folate metabolism and methionine synthesis, modify DNA methylation status in interaction with folate levels. General consideration regarding dental treatment. The dental treatment for leukemic children can be broadly divided into 3 phases. Phase 1, dental and oral care before initiation of cancer therapy. Phase 2, dental and oral care during immunosuppression period. Phase 3, dental and oral care after cancer therapy is completed. Phase 1, dental and oral care before initiation of cancer therapy to identify and stabilize or eliminate existing and potential sources of infection and local irritants in the oral cavity without delaying the cancer treatment. To educate the patient and parent about the importance of optimal oral care. Initial evaluation of oral and dental examination include reviewing the child's medical history, reviewing the current hematological status, reviewing the proposed chemotherapy radiation protocol, completing a thorough head and neck dental examination including panoramic and bite-wing radiographs. Phase 2, which is during dental treatment oral care during immunosuppression period. The objectives of dental care during chemotherapy are maintaining optimal oral health, treat side effects of anti-neoplastic therapy, reinforce the patient the importance of oral health in reducing problem discomforts arising from chemotherapy. Acute manifestations that develop during immune suppression are mucositis, gingival bleeding, xerostomia, secondary candidiasis, herpes simplex, and bacterial infections. Phase 3, dental and oral care after the cancer therapy is completed. The objective of a dental examination after cancer therapy ends as stated below, that is to maintain the optimal oral health, to reinforce the importance of optimal oral and dental care for life to the patients and parents. The patient should be seen at least every 6 months or in shorter intervals if issues such as xerostomia or trismus are present. Management of leukemic children in dental office. Management of leukemic children in dental office should be done through a protocol. To start with, begin with proper blood investigation followed by radiographic examination. Panoramic radiographs and intraoral periapical radiographs should be considered in patients who are cooperative. Patient assessment. To arrive at correct diagnosis and subsequent treatment planning, proper medical history are key necessities. Details of chief complaint, history of present illness, medical condition of the patient should be obtained. Medical consultation. The dentist should follow an overall comprehensive care of the patient by coordinating with the patient's physician or pediatrician during the patient's physical conditions, medications, sedations, GA, and other special preparations required to ensure the safe delivery of oral health care. All parents should sign and inform consent before any dental procedure in the dental office. Patient and caretaker education. Most important ways to reduce the incidence and severity of oral sequelae in leukemic children is to practice routine oral health care. Patient's physician should be educated about the oral pediatric medications which may be carcinogenic. This medication should be replaced with those which is not carcinogenic if possible. Preventive protocol include oral prophylaxis, pit and fissure sealants, and topical fluoride application should be done irrespective of the hematologic status of the child. Soft toothbrushes and electric toothbrushes can be preferred for plaque control. Endodontic treatment protocol. Pulp therapy of primary teeth is contraindicated. Endodontic treatment for permanent teeth is also not recommended. This is because even with the most exacting technique, an area of chronic inflammatory tissue may remain in the periapical region of endodontically treated teeth. Loose primary teeth should be allowed to exfoliate naturally. Extraction of non-restorable teeth, root tips, teeth with periodontal pockets of more than 6 to 7 mm, acute infections, percussion involvement, teeth with bone loss should be done before chemotherapy. Oral surgical procedure should be done before the commencement of radiography because of the high risk of osteoradionecrosis. Ideally, dental extraction should be performed 3 weeks before starting cancer therapy to allow epithelialization of extraction site and adequate healing. Several authors recommend at least 7 to 10 days before the patient receives myelosuppressive chemotherapy. Extraction cannot be delayed, performed at a platelet count of 40,000 to 50,000 millimeter cube. In any cases, neutrophil count should exceed 1000 millimeter cube before any dental surgery. Periodontal therapy, partially erupted molar pose risk of pericoronitis. If hematological conditions of patient permits, pericoronal tissue should be excised. Periodontal treatment should be done either before therapy or after, but not during the therapy. Orthodontic therapy, craniofacial, skeletal, and dental development is delayed in cancer-survived children who are less than 6 years of age. Growth prediction is an important parameter during planning of the orthodontic treatment. Since the skeletal growth is delayed, problems to the cancer survivors for orthodontic treatment. Orthodontic care should start 2 years disease-free survival when the risk of relapse is decreased. The following strategies should be considered when providing orthodontic care, that is the use of light forces, use of appliances that minimize the risk of root resorption, termination of treatment earlier than normal. Poorly fitting appliances which abrade the oral mucosa should be removed. Oral hygiene, if the oral hygiene of the patient is poor, the appliance should be discarded. Removable appliances and retainers that fit well and those which can be tolerated by the patient can be delivered. Fixed orthodontic therapy should commence before the chemotherapy starts. To conclude, oral health status is compromised in patients with acute lymphoblastic leukemia, and affected children require dental care before, during, and after treatment. Regular oral examinations are recommended, and dental care should focus on maintaining the dental health and treating the long-term effect of therapy such as tooth morphological disorders.